Hello, today I want to introduce A.G. Lely, Professor Doctor, and it's a great honor for me to be here and to ask questions to him. Now I want to ask you, would you like to give information about acromegaly treatment, about new options now in the world? Could you please give some information about these treatments?
I will. Thank you for the invitation, and I'm happy to do so. The acromegaly treatment, at least the medical one, started in the 80s of the last century, where bromocriptine became available. Later followed by the somatostatins, first the subcutaneous form and later on the long-acting form. In the last, say, 20 years, somatostatin analogs are now accompanied by two newer compounds. The original and long time available octreotide and lanreotide long-acting formulations now have a twin sister, pasireotide, that is also injected in a long-term injection for 4 weeks. The advantage is it's slightly more potent than the octreotide, lanreotide. However, the side effect is that you induce hyperglycemia or in some instances diabetes as well. For all these three compounds, octreotide, lanreotide and pasireotide, for untreated naive patients, you might expect normalization of IGF-1 to about 50% max. The drug that became available in 2004, depending on the area on the world, is pegvisomant. It's up to now the most effective treatment for active acromegaly. It is the only GH receptor antagonist. Pegvisomant is in fact the GH molecule with a few mutations so that it sticks to the GH receptor but does not allow signal transduction. And the endogenous GH cannot reach the GH receptor when it is occupied by the pegvisomant compound. Now, pegvisomant is a competitive GH receptor blocker. And pharmacology dictates that if you give enough, you will block all of the GH receptors and you will normalize IGF-1 in virtually all acromegaly patients. There are up to now no pegvisomant resistant patients described. In the literature, the normalization rate of IGF-1 during pegvisomant is about 70%. The 30% that is not normalized is not because they are insensitive to the compound, but that is because the doctor does not prescribe enough or the patient doesn't have the financial means to pay for this compound because it is a very expensive compound. In the near or far future, there will be several new compounds that will be introduced. The first one is a new somatostatin receptor agonist, but it's a non-peptide, a small molecule, and because it is a non-peptide, you can give it orally, so as a tablet. The Crinetics company has made paltusotine, as it is called now, and it is in phase 3, so it will hit the market very soon. Once daily, one tablet, does the same as the monthly injections of octreotide, lanreotide, and pasireotide. There's another company called Alexion who is developing a small peptide GH receptor antagonist, but because it is a peptide, you have to inject it once daily. That is currently between phase 1 and phase 2 in the clinical phase. I think that is the overview of what is already available and what is coming.
Thank you very much for your comprehensive information about this condition. And what do you think about it? Is there any improvement about acromegalic incidence of how can I say, in the world? Perhaps increasing acromegalic patients will increase or decrease. What do you think about it? Because we can see rarely this disease, but we come across lots of patients in the future, or few patients. What do you think about this situation?
I think it is very difficult to assess whether the incidence of acromegaly is going up or that patients are recognized earlier. Up till now, at least in our experience in the Netherlands, it still takes about 7 to 9 years before patients are diagnosed and after the symptomatology started. You can see, for instance, on pictures or driver license and passports that you already had the disease for quite some time. Now, the Netherlands is a very small country, and all patients have a general practitioner. So we thought in the past, why not send a leaflet to all general practitioners with a very simple message. If your patient looks like this, as a classical acromegaly patient, and complains about headache, fatigue, arthralgia, and carpal tunnel syndrome, please measure IGF-1. If elevate, please call this number. And we hoped, and we did expect, that there would be a sudden increase in the incidence because we made GPs aware of it. And we resent the same leaflet 3 months later, but we didn't see any change in the incidence. And I think also for general practitioners, if you see an acromegalic patient once in your whole career, psychology dictates that you don't believe what you see. And I think that's the fate for patients with a rare disease. Even if the doctor thinks about it and it is rare enough, he or she will probably say, no, that's impossible. In my practice, I can't imagine.
Yes. Thank you very much for your comprehensive lecture again. And thank you.
I'm Dr. Tuğçe Apaydın, and I would like to ask a few more questions. Some centers are choosing to monitor cases of silent acromegaly rather than opting for surgery. I'd like to ask your thoughts on these cases where patients don't display the typical features of acromegaly.
The differential diagnosis of an increased IGF-1 is relatively small. It is either acromegaly or GH excess, or the excess isn't produced within the patient but given out from outside. So GH for doping purposes. If a patient doesn't look like an acromegalic patient, I would not be able to diagnose acromegaly or a silent one because I don't measure IGF-1 in patients that don't look like acromegaly patients. I do measure IGF-1 also in patients in whom I suspect GH deficiency, which is very different. But silent acromegaly, there are nationwide investigations following whole quarters of a city in the Netherlands, the Rotterdam study, for instance, where everyone who's living there gets an MRI of the brain. And then by coincidence, quite a still small number, but there were quite a few patients who had a pituitary adenoma. Now, the MRIs of nowadays are so sensitive that 10-15% of people have something in the pituitary, albeit very, very small. So what to do then? If it is a macroadenoma, we get 4 or 5 patients referred that have no complaints at all. Sometimes they have one deficiency in the anterior pituitary, but that's about it. We haven't found an acromegaly patient in that way yet. But the diagnosis is made on site. It's the phenotype that makes you aware, and it takes a lot of training to be able to see the phenotype. But if you're well trained, you can spot an acromegaly patient. If somebody walks in, we'll immediately say, you might have acromegaly. But it's still a rare occasion. A recent example, I was going through one of the Dutch newspapers and I saw a small picture of a cocktail reception somewhere that had nothing to do with acromegaly, but I spotted one person and I thought, hey, this is an acromegaly patient. So I looked for the name. I looked the name up in the internet, and there was a mobile number. So I called him and I said, this is going to be a very strange conversation, and I introduced myself, and I said, if you don't believe me, you can Google me, you can find me on the internet, but I think you have this and this and that, and I'll call you tomorrow. You look up acromegaly for yourself and think, this is what I have or not. I said, yes, this is what I have. So I said, go to your GP, ask for an IGF-1, and then if he is able or is willing to do that, call me back when you have the result.
Mhm.
It was at the other part of the country, but the GP refused to do that
Oh,
because
surprise.
he said, well, you're not a giant. So obviously the GP went to his own books or on the internet and thought, with acromegaly, you should be a giant, and you're not a giant, so I'm not going to do that. So in the end, I had to call a friend who is an endocrinologist in one of the nearby hospitals and said, can you get this person in and get him an IGF-1 assay so that we know? And in the end, it took 4 months before the IGF-1 assay was done because of the stubborn behavior of the doctor who did not believe that an expert can say something about rare diseases. And the IGF was elevated. So he is now on somatostatins up in the north, and he calls me now and then. So that already happened to me in a Netflix series. And Netflix series are looked at by millions of people.
Mm.
And I saw, hey, this is an acromegaly patient or someone with acromegaly phenotype. And I stopped at the end of that series and I looked at all the names and I went to the name and I looked it up on the internet. And then I sent him a mail and then he said, oh, what a coincidence. It's very kind of you, but I was diagnosed a week ago. And the series was already 8 years old. So I would kindly ask everyone in Turkey trained in endocrinology who has seen quite a few acromegaly patients, if you do spot one, be brave enough to approach a person and kindly start to introduce yourself and ask, do you know that you might have a condition that we call acromegaly? Because you really will be surprised at a lot of patients in which you can see that the patient has it, is not aware of it.
I did the same thing. I saw acromegaly patient in front of my door.
Yeah.
She was coming to my neighbor
Yeah.
for cleaning. And then I said, there's something in you I couldn't explain because, they can't understand firstly. And then I said to her, please come tomorrow nearby me. I introduced myself.
Yeah.
And then high IGF-1 levels I detected, yes.
Yeah.
The
Yeah.
same thing in front of my door.
And for these patients, it's very important that at least somebody in the end says, listen, sit down, we have to talk.
Yes. Thank you very much.
I'd like to ask your thoughts on the use of growth hormone as a doping or anti-aging agent, which is, we know, quite common.
Well, it depends on whether you want to be just older or look better. If you want to look better and if you want to lose your chubby fat rolls, start and use GH because it will induce lipolysis and you will burn away your fat. However, you will not become one day older. Very likely, you will be short-living because you will start to have a slight increase in cardiovascular disease. Maybe silent cancers already present in your body will start to grow faster. So I wouldn't do that. And there are a few models of severe GH deficiency in several populations on the world, and they live longer. So there are societies within the Roman Catholic religion, but also in the old China, where monks are living in a monastery that eat the whole of their life very minute amount of food, but very healthy. And their lifespan increases by 1/3. They get very old. And the reason for that is they don't get two things. They don't get cardiovascular diseases, and they don't develop cancers. So if you don't have GH, not optimal, but it's healthier than having a lot of GH at an age where your GH should be lower.
I'd like to ask one more question that is actually out of our topic. What recommendations do you have for those of us in the early stages of our careers?
In my experience, most endocrinologists over the world are nice people. And they don't mind at all that younger colleagues approach them and ask questions, start up discussions, ask for favors, try to exchange or go to other countries as much as possible, train your English, and the glass is always half full approach. Be positive. Don't be too shy. Nobody thinks that young people are a nuisance. And if somebody at an older age thinks that young people are in their way, don't talk to them anymore. They're not interested. So you shouldn't be interested in them as well.
Thank you for joining us today. It was a pleasure to have Dr. AJ van der Lely, and we hope to see you in our next episode.